Good morning. Thank you, Chairman Johnson, for the opportunity to share some time with you this morning. I'm Dave Gehm, and I am President and CEO of Wellspring Lutheran Services. We're based in Flint. We serve children, families, and seniors across the state of Michigan. We serve in about 50 of Michigan's 83 counties and serve about 10,000 persons a day. We've been around since 1893, so we've been at this a while, and are sort of unique in the fact that we serve across the age spectrum. We have a very large senior services portfolio of services that brings me here today. So, on March 10th, of course, the world changed for everybody, and restrictions and lockdowns came pretty quick, and no group of people, in my opinion, has been affected more than our elders who live in our care facilities here in the state of Michigan. They've been really without a voice until very recently. Their stories have not been told, and the impact on them has been sort of missed, I think, in the public square. So I appreciate this opportunity to raise their voice on their behalf. They've been scared, they've been lonely, they've been missing their loved ones, as we can only imagine. We know that the psychosocial and the mental health challenges of the pandemic are really hitting every age group. I think we'll find in hindsight that it has been absolutely devastating for our elders who are behind closed doors, shall we say. And early on, we knew very little about this virus, except that it did attack with sort of deadly force older folks with significant medical conditions, which of course describes the folks we serve in our state's nursing homes. They're frail, they're old, they have multiple medical conditions that make them very, very vulnerable. And so, when this began, we didn't have much to fight with. Early on, we struggled to get PPE, and so it seemed restrictions on visitation and lockdowns, if you will, absolutely made sense based on what we knew then. And so I'm not here to sort of relitigate that. What I am here to do is talk about where we're at now and how we got here. So as the initial surge of cases in May began to decline here in the state of Michigan, really across the nation, the Centers for Medicare and Medicaid Services in Washington published a new set of guidelines for us with respect to how we might go about reopenings for some visitation, and that was guidance, of course, for all states to take a look at. And we were very, very hopeful at that point. As we headed into the summer, case rates were dropping significantly, as you'll recall, and so this opportunity for a phased reopening was really exciting for our residents and our staff and certainly their families. So very quickly, under that CMS guidance, indoor restrictions could begin to be lifted based on county positivity rates. And if you were over 10%, there would be, in that county, there would be no visits whatsoever. If you were between 5 and 10%, there could be some limited visitations, and if you were under 5%, still limitations, but more opportunities for visitations for families. And so with that, we started to look at positivity rates, and really between June and October, Michigan, across the board, not county by county, but Michigan in total was below 5% for really from June to October. However, the state of Michigan did not adopt those guidelines and or otherwise take them up really in any way. What we did in Michigan was we sort of created a different version. Instead of having 3 levels, there are 5, A through E. And it's based on an algorithm that was created by the state working with the University of Michigan School of Public Health. And that algorithm has frankly confused us because as providers, we look at that algorithm and we see that there are many counties running below 5% positivity. And yet on the My Safe Start map that guides us with respect to the state's policy on this, we're at an E level, which means no visitations are allowed. So sadly, we really are essentially functioning under the same set of restrictions that were in place back in March of 2020. There are some exceptions, so I don't want to misrepresent that, but the core of the visitation policies right now are substantively the same as what we were experiencing back in March. So by way of example, looking at the numbers from last week, if Michigan had implemented the CMS guidelines and we applied them to the data we had last week, there would only be 2 counties in Michigan unable to open for some sorts of visits under the CMS rules. Applying the state rules, however, we had 38 counties that were at that E level and therefore had no visitation. So you see the difference in that. And for some specifics, Ionia County recently was posted at a 10.1 positivity rate. Saginaw County was at a 3.3. Yet on the My Safe Start map, they were both level D, meaning Ionia could be open, even though if you applied the CMS data, they wouldn't be open for visits. And Saginaw at a D had some very restricted visitation, but if you applied the CMS rules, they would have been much more able to accommodate more visitors. So that's one example. Lenawee County is interesting as well because it's at a 4% positivity rate this past week, and a level E on the My Safe Start map, meaning no visits. So those examples to me underscore the opportunity and the importance for us to think about a more nuanced, maybe locally determined policy that takes visitation needs of residents to heart. So the other thing I would say is that conditions have changed so significantly since we started this back in March of 2020. We now have adequate PPE. We have inventories. We're ready if another surge comes. We have that. We have weekly and biweekly testing as needed for residents and staff. We have the ability to do rapid tests at the door. We have therapeutics that lessen the severity of the illness. Monoclonal antibodies have proven to be very effective in the elderly and are available. And of course, we have vaccines. And the vast majority of care facilities in Michigan now have been through their second and even third vaccine clinic. We're seeing numbers between 85 and 95% uptake by residents in those facilities. And interestingly enough, there's studies coming out now that looked at facilities who, after their first vaccine clinic, saw a 48% drop in cases, whereas facilities that had not had any vaccine clinic yet had only seen a 21% drop. So as a community drop, you would expect that. But we saw more than double the rate of decline already in those facilities that had their first vaccine. So we know that's beginning to work. So we would just offer a revised policy that could take into consideration opening up under certain conditions for residents that have the vaccine. They've got strong immunities building. We would rapid test families at the door, and we can do that, and then clear them for entry. We would allow visits in separate rooms that are not inpatient areas that would be sanitized between visits. We would limit visitors to 2 per family for an hour, and of course, masks and some distancing would be required. In our opinion, those would be very safe conditions given what we now have and the vaccines in 90 to 95% of the arms of our residents. So we are seeing physical and cognitive decline in our residents. The chairman mentioned, the lack of appetite. People are just giving up. And now that we've got the vaccine to the extent we do, there was great hope among our residents as they took those vaccines. They had assumed that by doing that, this was their ticket to see their loved ones. And yet nothing has changed, and some of these vaccine clinics go back to late December. So what we need to recognize is the impact on these folks, like anybody in life, if we lose our sense of purpose, we begin to decline. Our overall psychosocial, spiritual health and wellness begins to decline when we lose purpose. What we need to recognize is that for our frail seniors who are in assisted living facilities, in nursing homes across the state, family is their purpose. They don't have a whole lot left. And by allowing this to go on, we're seeing that decline happen faster and faster now. And so, you know, for us, there will be a time that we look back at this pandemic and we will recognize that we lost some things, we missed some things, we had to cancel events, we didn't get to do things, we didn't make memories that we might have. But we'll look back at this as a time in our life and understand that it was part of that. But for our residents, this isn't just a time in their life. For many of them, it's the rest of their life. And so it's time for us to open up. And really, it's time for us to hear their voice and to give seniors a say. So thank you.
Thank you. I believe Representative Brixey has a question.
Thank you very much for coming and sharing your concerns with us. I have a couple questions. Is your organization a nursing home, or do you serve people in facilities?
We operate 4 nursing homes in the state of Michigan and a large assisted living facility. We also do a fair amount of affordable housing for seniors as well.
Okay, and so I'm quite confused by your comments because the work that that I've experienced in my office with DHHS is that most of the problems that we've had with our constituents wanting to visit their relatives in nursing homes are arising from not from the governor's orders, but from the nursing homes taking steps above and beyond the orders that are in place. So, for example, last May, we had a woman who had come in from out of state. Her mom was very sick and was dying, and she was in the hospital. And then she got discharged into a nursing home on hospice. And, you know, they only allowed the outdoor visits. And we discovered that it was their own policy that was preventing them from allowing them in. And we did work with them, and it was complicated because they own facilities in many different states, and they have a complex series of regulations. So, are your regulations based on which orders are you using? Because people can visit as long as you're COVID-free within 14 days. You can have visitation.
So if I may, the guidelines as we understand and apply them is that a facility, once it becomes a D level or higher, that is A, B, C, or D on the My Safe Start map, and hasn't had a positive case in 14 days, can begin to open up for very limited visitation, which is why I underscored the difference between what we're seeing in CMS level positivity rates and what we're seeing on the My Safe Start map, where we have facilities that are at 4% positivity rate counties haven't had a case, and yet they still show up as an E on the My Safe Start map. That's where a lot of the confusion is coming. With respect to end-of-life visits, those have always been allowed all the way back to March. But I think we've had some just different interpretations of that over time. I think providers weren't clear and probably in some cases still aren't clear what end-of-life visits really mean. Some interpreted that to mean that residents had to be actively dying. Mm-hmm. And so, that's an art, not a science, when you're looking at someone with these levels of frailties and on hospice. And so I know that it's a constant conversation to look at every case by case and say, can we apply this to the guidelines as we understand it?
Thank you for that. Oh, do you have another question?
Yeah. Aren't some of your facilities, are any of your facilities allowing visits?
So we are. We have a couple of facilities that are in D level and have not had a case in 14 days, and so we sort of sort of hang on the thread of hoping we don't see another case pop up. But we have a couple of facilities that started visits last week. I'd love to describe the joy that's creating for those folks. Limited, but available. And
Did you happen to see the news this morning? I saw they released some new information about the dramatic drop in nursing home deaths across the country, which really made my heart sing because my parents are in a facility themselves. And so to see that we're beginning to gain the upper hand in this is something that's very comforting and hopeful to me.
You're referring to the article in the New York Times, I
Yes,
think? It was a great article. And
That's what we base our information on the news.
And so just to, sir, you're out of order. So I've heard a lot of stories on this where people in facilities where you have that 14-day window, and so they'll schedule out appointments for family members, on that next day, and then day 13 in a large facility, one person gets COVID, and all those appointments are canceled. And it's just, they keep clinging to this hope of, all right, I'm going to see my family members, and then it just gets taken away from them. And it's just despair for these people.
so we actually had that happen in one of our facilities. We were gearing up for visits, and a staff member case popped up. Frankly, we're not even sure it was related to work, but nevertheless, you start that 14-day clock again, and we had to cancel visits at that point.
Representative O'Malley.
Thank you, Mr. Chair. Thank you for your presentation today. A couple of quick questions. First of all, to some of the points and questions that were raised already. With over 1,000 frequently asked questions and this sort of thing, when your organizations and groups like yours get these new rules, they're not always crystal clear, are they? So there's confusion as to their interpretation?
So that's absolutely right. A lot of guidance comes out. In fact, at one point, I haven't looked lately, but at one point, the inventory of guidance we had received from something like 12 different overseeing bodies, national, state, local, was somewhere over 300 different pieces of guidance that we got. Some having to do with labor law, some having to do with visitation, some having to do with infection control. I mean, you name it. And so we're constantly assimilating that, trying to interpret it, trying to apply it, and frankly, trying to figure out what previous guidance this supplants or doesn't it, right? And so I think that's just the condition of COVID, though. I don't think that's anybody's failure. I don't think it's. I just think it evolved quickly. I called March and April for us the sort of the fog of war because everything was coming at us fast. And while that's settled down a bit, there's still a lot of regulatory guidance out there for us.
Sure. Quick questions. When it comes to guidance from DHHS, how timely are they? And I'll give you my example. When I was in the Oversight Committee over the summer talking with Dr. Gordon, and there was the visitation. Well, we're outside, that's great. But it was already late September. We were heading into October. My community, temperatures are dropping. And they didn't come up with any indoor suggestions for several weeks after. So I'm just curious as to how timely this guidance and new rules come from DHS, in your opinion.
Yeah, so I think DHHS has done everything they can to stay ahead of things. Having said that, we of course would like guidance sooner rather than later. We have been asking for consideration for indoor visitation since really May and June, particularly after the CMS guidelines came out. We were very interested in getting guidance from that. It did come out later in September, but again, it was a different sort of a different model that didn't really approximate what CMS had offered.
All right, and one last quick one. The governor's task force on nursing homes came out, and when it hit, there wasn't a big move to implement those. Where are they at on the task force recommendations?
Yeah, that's a good question. There were multiple task forces underneath that major task force, and I would have to get back with you on that specifically, but I would just say that some of those recommendations were implemented, some have not been taken up. I sat on the sub-task force on staffing, and we've seen a little bit of movement there, but we've got a lot more to do on that.
Thank you, Mr. Chair.
Thanks. Representative Outman.
Thank you, Mr. Chair. Are you seeing patients at these long-term care facilities being vaccinated at an adequate rate?
Most of our facilities are over 90% for residents vaccinated with both the first and second dose now.
Okay, that's terrific.
And that's the data across the state that we have.
Okay, I would say in my district, that's not the case, but,
For residents?
pardon?
For the residents of these homes?
Correct.
Okay.
Yep. So I was just curious to see if that was the case in your opinion statewide. So thank you.
They're at 90%. They should be open in my mind. I mean, that's well over the goal. Representative Riley.
Thank you. Well, these COVID hearings are kind of like just beating a dead horse, but I'm going to ask you this question anyhow. From your testimony, I would expect that you were going to say that you're okay with guidelines, but all the thousands of decisions that you make daily would be best left in your hands instead of the state of Michigan telling you what to do on everything. Would you agree with that?
So I would agree to the extent that we need to have the regulatory guidelines that create the sort of guardrails and safety nets for our frailest people. Within those, to be able to make good local decisions based on what that facility, community, county is doing with respect to COVID makes a lot of sense. And you know, we're motivated by the care for our residents. Our staff have been their family, and it is breaking the hearts of people who have dedicated their lives to serving these frail seniors to watch this go on, and doing everything we can to advocate for a change in this policy. But I think with local health departments, with the data we have, with the testing we have, with the vaccinations having been done now, I think good local decisions can be made within the guidelines.
Thank you for that answer.
Representative Young.
Thank you, Mr. Chair. Thank you so much for being here today. This is so difficult because we care about our seniors, we care about families, we care about kids and virtual learning. And so I'm curious to know that whether or not you all offered any type of video conferencing. The one thing we know is that there's nothing that replaces personal contact, but I know in Detroit we did a full-fledged effort to get tablets in homes so that people can still see loved ones and hear their voices, and if you did, and it looks like you did, what was the response of some of those residents?
Yeah, we did. We bought what we could. We frankly had a wonderful outpouring in our communities of folks donating sometimes used, sometimes new tablets and so forth. And they worked well enough to get face-to-face visits. The challenge that we face is that, particularly for folks with memory care and dementia, that in most cases added to confusion. Never having done that before, taking a 95-year-old who's had dementia, has trouble recognizing family already. Frankly, we've noticed folks sort of looking behind the tablet because they didn't understand what this was. And so it didn't work for everybody by any means, but I think facilities across the state leveraged that as much as they possibly could.
Representative Wozniak.
Thank you, Mr. Chair. Thank you for your testimony. I'm an elder law attorney, and I'm very familiar with your organization. Your group does great work throughout the state. We're very fortunate to have you in Michigan. And thank you for coming today. So I have two quick questions. First one is, how are you doing with staffing vaccinations? Mm-hmm. And number two, how are you paid for the COVID people that came into the nursing home?
Mm-hmm. So staff vaccination rates are lower than residents, certainly lower than we'd like even. We have facilities that are in the high 60%. We have some facilities in the mid 30%. And frankly, there's been just a challenge getting staff to accept the vaccine for all kinds of reasons. Some because of faith beliefs, some because of their own personal health concerns, some because we know there are racial and ethnic disparities in healthcare and in how this disease has affected folks, and so there's been just hesitancy. So we continue to try to educate and push and support that. The question with respect to payment, payments for us didn't really change. When somebody would contract COVID, CMS did change the rules for a period of time under which we could put somebody, say, off of Medicaid onto a skilled Medicare visit because their conditions had changed. Normally, you need a 3-day hospital stay before you can do that, right? So, so payment would change because conditions change, but not because the payment system changed for us. Obviously, we have other additional revenues coming through CARES Act grants and other things that helped offset the additional costs somewhat and so forth for PPE and now for testing and that. But the payment mechanism didn't change.